So, introduction from me. My name's Dr. Ollie Hart. I'm a GP in Sheffield. I've been a GP for 25 years now. I know it's hard to believe, isn't it? I'm also a clinical director of a primary care network in Sheffield, which I've done for the last 6 years. Really proud of that role and how we brought out new roles like health coaches and social prescribing link workers, and I have a lot of experience of putting them into action in our network and supporting others to do the same. But probably one of my key roles now is as director of peak health coaching. So many of you will have heard of us. We train health coaches across the country, social prescribing link workers, care coordinators, and we produce sort of training for health coaching skills across all sorts, expert patients, GPs, nurses, and social care. So I'm a real advocate of I'm going to mute people in the background. I'm a real advocate of the importance of health coaching, and I'm that's because of my own personal experience of a GP. In my own personal experience, if a patient is more engaged and more involved and more in control, they tend to do much better. And I think health coaches play that essential role in helping people to take the lead as best they can. So, thank you very much. 23 of you responded to a sort of a pre-session questionnaire, and these are the things you told me you'd like. So, you wanted some background knowledge on how GLP-1s work. We'll certainly do that, and the benefits and side effects. You're interested in information you could signpost patients to. We're going to finish off with that at the end. You're particularly interested in how you can support people whilst taking GLP-1s and then also coming off, and we'll give time to think about that. Some of you said you want to have conversations that inspire people, not enforce them, and I like that phrase, and we'll bring that in. And you wanted some case examples, so Emma's going to do that. And for me, this is really about, I guess, being clear about what's in and what's out of scope of a health coach. You don't have to do everything, but what you do can be hugely valuable. So what is it that adds best value as a health coach? I think that's a key question for all of us. So what we're going to cover, we are going to, I'm going to give you a little background about my view on health coaching context. Then I'm going to dive down into some of the descriptors of what insulin resistance is and what's happening in metabolic dysfunction, which I think is really important because that's the context where these GLP-1s are working for both diabetes and weight loss. Then we'll dive down into knowledge about, we call them incretins, don't they? These proteins that the body naturally makes, of which GLP is one, how they work and the benefits and risks. And then we're going to come into what's happening in the real world. You'll be able to contribute to that, but I've got some comments as well. And then we'll think about health coaching support. So that's what I'm planning to do. Like I say, probably now about another 40 minutes of me talking at you, and then we'll have plenty of time to have some interactive debate and discussion. Okie dokie. So I guess this is the first slide for me, and this is a sort of dilemma we hold as coaches, isn't it? And I guess the key thing is we know that if a patient is driving their own bus, if they're the one in control, everything tends to work better, doesn't it? There's so much evidence behind that. The self-determination theory, salutogenesis theory, the transactional analysis, so much evidence-based behind that. Could go on and on and on. And that leaves us in a real dilemma as coaches, isn't it? Is actually we want to keep the person in control as much as we can, but we want them to have really good information. We want them to be working off high quality knowledge and information about treatments available, about what they're doing, about how they self-manage. And I often draw the conflict between information, high quality information, and giving people advice, if you like, telling them what to do. And the former is great, that giving someone advice and trying to be you're in control, you're in the driving seat rather than them can be a restrictor. So there's this dilemma, isn't there? The other two I think that's relevant here is that, of course, one size doesn't fit all. People are in very different personal and social situations. So, a middle-aged mum with kind of like looking after elderly parents, coping with young children or children with ADHD, or, as people often are, so juggling a difficult boss at work. They're in a very different situation, perhaps, to someone who maybe is a bit older, has got a bit more time on their hands, and is starting to rediscover self-management themselves. So it's very variable how we support people, isn't it? And you, of course, will know this. But the other thing I wanted to get on the table is that our understanding is changing all the time. I've certainly felt more humbled and sort of more modest in my career, because what we were saying 10 years ago is really out of date now. And what we were saying 10 years from now will probably be quite different. We are learning of how the body and neuroscience works. It is changing. The human body isn't changing, and there's some things that are very fixed, but our understanding of it is definitely evolving. So perhaps hold some of this stuff with a little bit of lightness, if you like, that things may evolve. So this is reasonably new. I very immodestly call this Hart's health coaching hierarchy. You've heard of Maslow's hierarchy of needs. And when we think about how we teach health coaching, but also how I think it's applied, I think there is a bit of a hierarchy, isn't there? And I just wanted to just put this out there. It's reasonably new. I've sort of blogged about it on LinkedIn. And it's about getting the foundations right. So for me in health coaching, the foundations is people's self-belief. What are their capabilities, if you like, really? In a way, you can ask, are they able to be in the game at all of looking after themselves? And that is so important, isn't it? Do they feel that they are worth it? Do they feel it is worth it at all? And I think the core bit of health coaching is about building that self-belief. And if you do nothing else with your health coaching, building that self-belief and having the skills to do that, because it's not always easy, is a really essential task. And no one else is really doing it that well in the system, be it in the NHS, in workplaces, in all sorts of locations. So that's a key role you play, and it's the foundation. But then, of course, on top of that, we build an attention to some of the generic determinants of health. And what I see there is sort of, those lifestyle pillars, sort of exercise, diet, sleep, how we manage stress, the substances you may be using. And the social determinants as well, those wider determinants of health. And I think as good coaches, we start to pay attention to that and work out what are the key things for individuals. And we build our knowledge base around that, but it's quite generic. And then on top of that, we then build condition specific skill sets. And that again will really depend on your background, your scope of practice, your previous training and ongoing training that you get. And that will be quite specific to an individual and their condition. And this is a great example of that, isn't it? When you're looking at working with people with GLP-1s who often have insulin resistance and are metabolically unwell, actually having a little bit of background knowledge can really help you to support them. But you mustn't forget the key thing is building that self-belief and making sure the kind of generic determinants are right. So don't get distracted by the kind of sophisticated stuff from doing the core job, which are the foundations. I just wanted to put that on the table, really. And we can discuss that later. So in the theme of hierarchies, I'm going to draw Rashani Sagani's hierarchy together around what can we change in metabolic health? What other things that we as coaches could influence in terms of the lifestyle sort of thing? And what I like about Rashani's book, and she's not the only view, is that she almost has, again, a little bit of a hierarchy. And she suggests that at the bottom, we have to get people's nutrition right. If they don't understand the basics of nutrition, and then we're stuffed. On top of that, we can then build good quality sleep. Again, if people are sleeping really badly, actually, it's a real it's a real sort of disabler for anything else we're going to do with them. Because then the two other things you work on top, very easy to see, is how we deal with stress and how we build an activity. And she kind of has a deliberate order in this that actually, you get the nutrition right, you get their sleep right, you can have some quick wins quite early. You then work on their stress response. We all have stress in our lives, don't we? It's how we respond to it that matters. Have we got high sympathetic tones? Some of you will be familiar with that. Or are we able to be more in the rest and recovery phase more often? And that phase is something we're trying to build as coaches, isn't it? And then activity tailored to the person, appropriate movement builds on top of that once you get those things right. And she talks about fasting, which many of you may well use, as something to be perhaps a little bit cautious about, because if you haven't got the nutrition right, if people are not sort of moving well, there's a real risk that fasting can lose muscle and can actually pull you backwards in metabolic health. And that's going to be really important when we talk about the role of what these GLP-1s do and how they can effectively induce fasting in people and the risk of losing muscle and lean mass. That'll come in a minute. But I recommend Rashani's because it's quite thick, but it's a good read if you want the real background around metabolic health. So I have to remember to keep drawing breath. I hope you're flowing with me. So I'm going to just spend a little bit now, unapologetically, I'm just going to take you through what I consider the basics of metabolism. And I think it's really important to have this. And for some of you, I know you'll absolutely be familiar with it, but it's a way we talk about it in the course we do at Peak Health Coaching. And I've used this with patients. I know patients get this as well. So I think it's useful to know. So the mainstream of how we manage our metabolism is how we process sugar. There are other things that come in, but how we deal with sugar is so important. And many of you will know that we're really tight with the amount of sugar we have in our bloodstream. So this is an illustration of sugar in a red blood vessel. So I want this to indicate our whole situation. And what we're so tight that actually we aim to have just one single teaspoon of sugar in our whole 5 liters of blood. That's how tight we control sugar normally. And even the worst controlled diabetics don't get above 2 or 3 teaspoons of sugar in the bloodstream. And even just an extra half teaspoon in your bloodstream would put you well into the diabetic range. So we're so tight with this, and there's a really good reason we do that, which we'll come to. But the way we do that, sugar in the bloodstream gets taken out by the hormone insulin. And I'm sure you know this. So it's the prime mover of sugar. And what insulin does is it puts sugar into the tissues, into the muscles and the brain. And that's great. It helps us to do the things we want to do, helps us to exercise, to think. We even have it at night whilst we're sleeping. Now, the trouble comes if the sugar levels start to build up a little bit. What the insulin does is it tries to put sugar into the muscles and the tissues. But if they're full, if they've got enough, what insulin does quite reasonably is stores sugar as fat. So that's one of its job. Put it into tissues. If there's enough there, store it as fat. A really good thing. Save it for a rainy day when there's less sugar around and we may need to reverse that process and burn off our fat. So it's a really good thing to do. Now, of course, as the sugar levels, volumes in the bloodstream continue to rise, we worry, don't we, that what that causes in the short term is some symptoms, but also in the long term, we know, and the body knows, it damages us. So actually, this is a real imperative, is to not let the sugar rise above that 1 or 2 teaspoons in the bloodstream. So if we see sugar levels rising more again, we produce more insulin. It's got an even stronger message to put it in the tissues. The tissues are really full now, so we're storing more as fat. And again, that process carries on up to a point. And we reach what some people term, Roy Taylor calls the fat threshold. And it's different for all of us. You'll see some people who are really skinny and they build up fat around the internal organs quite quickly, and they can look skinny, but they've hit their fat threshold. Other people are actually really talented at storing fat. And I say that it's a talent to store fat. It's been a survival technique. So the more fat you can store in your peripheries and your limbs, around your legs and your bum and so on, actually, the better survival it was. So we've selected people for that. And you could look at people who are overweight and say, you're very talented. If you've managed to be overweight and not get insulin resistance, actually, you've got a real survival talent. So maybe we should look at it a bit differently. But nevertheless, when you hit that fat threshold, the body's basically saying, look, for you, you've got enough fat stored. And the way it then feeds back is to say, look, we're going to stop the insulin from working so well. We've got enough fat. So you develop insulin resistance. Insulin stops working as well. And that would be great, wouldn't it, if we stop the sugar coming in? But if we keep the sugar coming in, what happens is you get caught in this vicious cycle of insulin not working so well, so the body has to make more insulin. So you get high insulin levels, which are very damaging themselves. Tries to force more sugar in the tissues, lays down more fat. So you just get this vicious cycle. And this is the vicious cycle of type 2 diabetes. And it carries on for a point, carries on as much as it can. But if it gets to a certain point where you just can't keep up, that cycle can't keep up, then you really back up sugar in your system. You see the sugar levels really shooting really high in your bloodstream. So that time when the sugar goes up to a level where we diagnose pre-diabetes and then diabetes at 47 millimoles is actually the end of a sort of 10-year process. We've been trying to keep up with this, laying fat, insulin resistance for most people for about 10 years. So thinking of diabetes as like sort of, oh, that's the point when we ought to worry. We should be worrying much earlier. So actually this insulin resistance is really important. I'll just put that on the table there. So effectively what's happening is your body's in this fight, this metabolic fight between storing fat and having too much fat and not wanting that much sugar in your bloodstream. It happens at any age, and it's not surprisingly, it's exhausting and it's very damaging to the body if we're fighting with ourselves. So let's look at what causes the sugar in the system. And I know I'm going to a bit of detail here, and I am recording it. You can look back at this afterwards if you want to go through it more slowly. So where's the sugar coming from? Well, we mustn't forget that the body makes sugar. We make it in the liver, and we make it in response to stress, particularly the stress hormones like adrenaline and cortisol cause the liver to make more sugar. Poor sleep, those sort of things. So we need to keep that back in the back of our mind. And actually, what's worth remembering is actually we can make all the sugar that we need through the liver. So whilst we do need protein and fat in our diet, they're essential. We don't actually need to eat any sugar at all. We will not die if we don't eat sugar. And of course, that alludes me to where most of the sugar comes from what we're eating and drinking. And when we think about that, we think about the small sugars, the single units of sugar. These are the ones that are labeled on the front of the packets as sugars. We taste them as sweet. But we also, of course, mustn't forget that these sugars come in long chain carbohydrates as well. These small sugars all holding hands together. And they're not highlighted on the front of packet with traffic lights. You have to look at the back of the packet and see the carbohydrate content. And for most people, in my experience, that's where most of their sugar's coming from. The starch in things like bread, pasta, rice, potatoes, breakfast cereals. That's where most people are getting their sugar from. And what's driving this whole process? Again, I know many of you will be really aware of it, but it's just really important to keep that in the background. So I'm going to just come back to that in a second, but I'm going to now talk about these incretins, or these group of proteins that we naturally make in the body. And this is what we are working on when we're looking at GLP-1 receptor agonists, or kind of mimickers of GLP-1. We're mimicking the body's natural system. So we make a number of these proteins from the stomach right down to the large intestines, and we make them in response to food being in our system. So we've got very good feedback loops in our body that help control things, haven't we? So we make a number of these. So GLP-1 is made right from the stomach down to the large intestines. GIP, which is the other one we're going to talk about today, is made from the stomach and into the small intestines. And they help us keep on top of things by having effects I'll show you in a minute. But what actually happens in the body is that these get released with food, but they get broken down very quickly. So there's an enzyme that breaks them down, usually within 1 or 2 minutes. So they're not sticking around for very long. And that's worth remembering. And that enzyme that breaks them down is called that DPP4, is worth just remembering. We'll bring that in a little bit. Apologies, I know I'm covering a lot of science, but I think it's quite good to have this in the background of your understanding how these things are working. So we're going to focus in on GLP-1 and GIP, because these are the two hormone pathways that are mostly being manipulated with these drugs that people are using. So what do they do? So GLP-1 on the right-hand side, multiple sites of effect. So they affect the brain, reduce our appetite. They have slowed down the stomach emptying, so stops food coming out, which makes us feel a bit sick and bloated, which is probably the main effects. But it also has a little bit of protection on the heart, and it also helps our insulin to be more sensitive. So it makes the muscles, insulin rework in the muscles again. It stops the liver from producing so much sugar, and it makes the pancreas perhaps a little bit more active. And we'll talk about that in a second. And then the GIP, a slightly different hormone, has a bit different effects. Again, effects on the appetite in the brain and effects in the pancreas. And it changes the way sugars are processed in the fat tissue and the bones as well. So has some benefits. Not as good as GLP-1, as you'll see in a minute, but it can be supplementary. So effectively, what GLP-1 are doing, if we go back to this chart, they're trying to reduce that eat part, what's coming in, by reducing our appetite and making us feel fuller earlier. But they're also having effects in the liver, and they're also making us a little bit more insulin sensitive again. So if it was just about trying to make insulin more sensitive, we might be actually aggravating this cycle. But the combination of these things tends to make them really useful for improving our metabolic health, but also losing weight. So that's how they're working in this sort of system. In another time, I could delve into why just piling in more insulin with insulin injections is not really a great strategy for people with insulin resistance, but that's another story. So what are the drugs? The GLP-1 receptor agonists. So they've been around for a while, over 20 years. They were started for type 2 diabetes, and Zenotide was the very first one. And you might be interested to know it was actually developed from lizard poison, lizard venom, because they realized that had a very similar effect to GLP-1 in the body. And of course, because it was a different protein, it wasn't broken down in that 1 to 2 minutes. So it lasts a long time. So effectively, you could inject into the body a kind of GLP-1 mimic that had all those effects, but stuck around for a long time. And initially, they were daily injections, and quite quickly, they got them to be weekly. As you'll see, there's a number of them out there, but the one that perhaps is most worth highlighting in the GLP-1s is the most common one used now is semaglutide. And that's where the really big studies that in obesity came from. And you'll recognize the names like Ozempic and Wegovy. They're just different trade company versions of this protein semaglutide that mimics the GLP-1 effect. I mentioned GIP. So the other one you'll commonly hear, Mounjaro, that's out there, is tirzepatide. Gosh, I always get a bit of a tongue twister with that one. Tirzepatide. And that combines GLP-1 with the GIP. And as you'll see in a minute, it seems to have a slightly stronger effect. So it's a weekly injection, and it kind of, if you like, the GIP enhances the GLP-1. Worth mentioning the DDP4 inhibitors. So I talked about this is the enzyme that breaks down GLP-1 naturally in the body. And you may have seen some of your patients on what we call gliptins. So sitagliptin or saxagliptin, allogliptin is quite common now. And effectively, they're raising the body's natural GLP-1 by stopping it being broken down. And there's not really a lot of point in being on both, because the injections kind of really supersede these. So if you see people on these and the GLP-1 injection, probably worth getting them taken off these. So what's the evidence base behind it? So this was the study that changed the world. And some of these slides are drawn from an American doctor called Mark Cucuzella, who I really respect. He's got a lovely balanced view to medical treatment alongside the self-management side of things. And I'm going to reference some of his stuff a bit later, but you'll notice I've credited a couple of these slides from him. And he calls this the study that changed the world. So 2021, it was published in big major journal. And this was the STEP studies, as they've become called. And this is around semaglutide, one of those proteins that's the Wegovy and Ozempic. And they showed that compared with placebo, the weight loss over time, by sort of like 28 weeks, you got massive weight loss, carries on to 68 weeks. So sort of 18 months down the line, people have lost 16% of their body weight. And you can see, when they looked at semaglutide compared with placebo, it's worth noting placebo still had some effect, 3 or 4% on a placebo, people lose weight, but 5%, 10%, 15, 20% weight loss, 20% of your body on the semaglutide versus placebo. So a really big effect. And when we looked at tirzepatide, I'm going to struggle with that all afternoon, aren't I? In the Sermont studies, this combination of the two, they got even more weight loss. So 25% compared with sort of like 4.5 with placebo. So placebo was similar to the STEP trials, but they seem to get bigger weight loss with the Mounjaro injection. So that's why that's become the really sort of common one. And subsequently, since then, there's claims now that these GLP-1s have effects around the body. You saw the multiple sites. There's effects in the brain. There's effects in the liver. And actually, there's lots of studies out there now that are showing that there's supplementary benefits. So sometimes people will be arguing for using sort of GLP-1s in some of the brain diseases like Alzheimer's and Parkinson's, and to have some direct effect on fatty liver disease, kidney disease, that cardioprotective effect. So sometimes you might see specialists using these for other things as well. I think it's just worth remembering that. This is quite a good review, the Forbes review. I'll send, you can look at these references later if you're the sort of person that really wants to dive down. So let's talk about side effects. So this is where it gets really important, isn't it? What are the side effects of these group of incretins? And I've tried to list these according to the top, the most serious, and the bottom, the most common. And I put a question mark beside thyroid cancer and pancreatitis because I know, although there was originally some studies that suggested these, more recent meta-analysis have called these into question. Admittedly, those meta-analyses are usually led by the drug companies that have obviously got a vested interest to disprove any problems. But the strategy I think we should take is that, if someone has a really strong history of thyroid cancer themselves or in their family, maybe you're going to be a bit more nervous about using these drugs in them. Again, pancreatitis, they've been well described in a rare but well described, a really serious life-threatening condition. But again, meta-analysis has suggested maybe that's just normal variation in the public. But again, if you've got someone who's had pancreatitis in the past or, is a high drinker and real at risk of pancreatitis, maybe you're going to worry about whether this is the right thing for them. Again, we're going to come to the fact that you're not the prescribers of these medications, so it's not your ultimate responsibility. But I guess you having this knowledge in the background really enables you to support them well, doesn't it? Getting more common, certainly there's been a lot of worry about how these can aggravate eating disorders like bulimia and anorexia. So again, if you've uncovered things that perhaps the prescriber hasn't known, or that you, with more time with people, start to realize maybe you've got a role in feeding this back, and we've got to question whether they're useful in people with those sort of disorders. And then getting to the big two, you'll probably have heard a lot around muscle loss. So again, studies vary between 0% to 40% muscle loss. And the STEP studies certainly showed there was muscle loss. basically because you're not eating so much food, there's a real risk you're not getting enough protein in your diet. And then what you're losing weight, not only from fat tissue, which is useful, get you back below that fat threshold, but you're losing it from your muscles. And of course, your muscles are a great burner of sugar, and keeping your muscles very important in metabolic health. Again, we can discuss that a little bit later. So again, if you're working with someone who's a big, strong, middle-aged rugby player or a solid, sort of person, then perhaps you're less worried. But if you're dealing with someone who's a bit more elderly, where you're really worried about the muscle loss, perhaps you've got to be a lot more careful. And I guess the final thing is gastro side effects, which probably happens in pretty much everybody. Well, when they looked at the STEP studies, 62% of people had, if we looked at groups as any GI disorder, but interestingly, people who are overweight tend to have quite a lot of GI problems anyway. So 40% of placebo, but 40% of treatment group had nausea and 30% had vomiting in the treatment group. And very often it's the GI side effects that limit people, that they just can't tolerate it because they feel sick all the time. And that's not much good, is it? So those are the most common things you're likely to see. So let's just come into the guidance in the NHS, and I think it's worth noting that this is, you talked about this, about people getting angry and not having access to it. There is very limited access to these medications for obesity. They're being perhaps more available for diabetes, or maybe even pre-diabetes that might come into, but certainly for obesity. It's only Mounjaro that can be prescribed outside a specialist unit, and in Wales, even Mounjaro's has to be prescribed in a tier 3 unit. And that in itself creates a bit of a problem for me, doesn't it? Because to access a tier 3 unit, a sort of specialist weight loss unit, you have to have failed tier 2. So the sort of things we do in terms of lifestyle and all those things that could be really useful for people, there's an incentive for them to fail them so that then they can get on and have the drug. And I think that causes quite a perverse sort of system in itself, which we could discuss. But in the NHS, you have to be BMI of over 35 unless your certain ethnicity is a little bit lower. And if you start it, you have to maintain 5% weight loss within the first 6 months on the highest tolerated dose, or it should be stopped. And because there's so many people in that group, they've got a sort of like rolling program. They're searching in GP practices like mine, and they're only pulling out the most severe to start off with. And they think it'll take them 12 years to offer it to all the people that fall into this group. So it really is quite restricted and only for the most severe at the moment. Which means, as you know, what's happening in real life, in the real world, is that most people are accessing this through private providers. So they're being prescribed by a prescriber, but very often it's a little bit unscrupulous, and they're just very happy to take the money for prescription with very little preparation. I know, have people had trial of a really good diet? Do they really understand a metabolically healthy diet and those tiers that Rashani described? And indeed, are they even monitored whilst they're taking them to look for, is it aggravating eating disorders and so on? So I've got no doubt you're seeing people who are having these medications with very little monitoring. And what's even more cynical is that as more and more people get them, that the drug companies just pushing up the prices. So it's only the sort of rich and famous these days that can afford it, because they're limited and the prices are going up. Eli Lilly just put the price of Wegovy up 3 times just in the last month. Tripled the price from 120. And it's in America, they charge even more. They charge £1,000 in America and charge £100 in Germany. It's crazy. All over the world, there's different prices depending on kind of probably how vulnerable people are. So it's a bit sick, really, in a way, isn't it? So it does mean that also people are using it outside the guidance. So rather than, the studies were all done in people who were on average 100 kilos or over, that BMI over 35. But now, whole host of celebs, you can probably name those. I think I can only name one there, but you can probably name more than me, and they're using it to get into their skinny jeans rather than because they are, morbidly obese and really unwell with it. You may have heard of compounded drugs, which is a thing that's becoming available on the internet. So this is a sort of an American thing primarily, where registered pharmacies are allowed to compound, which means supply a very similar drug that has a similar sort of effect. So it might be a different salt of one of the proteins or a slightly different formulation. And they get registered to do that. But often a lot of other pharmacies will do it without being registered. So it's often very poorly regulated, and you can get quite a lot of dose confusion, and there are risks with that. So it's really worth making sure that people are getting their prescription from a kind of a reputable supplier, because people will be accessing compound drugs from other places. And interestingly, what people are starting to do, you may have seen this, is they're starting to use Ozempic particularly comes in a self-dosing, you rack up the dose, the number of units. So people are starting to use those pens and realizing maybe I can get away with a little bit less, and maybe not every day, just use it perhaps if I'm having a bad time. And they're self-dosing, which I'm not altogether against, to be honest with you. It's not the kind of prescribing guidance, but it comes back to this bit of who's in control and what do you know about yourself. So interesting to think about that. And you may have had experience of people doing that, but that's the real world, isn't it? So I know I'm rattling through this, but I want to get to us to be able to discuss this and so on. But of course, the real worry with this is that when they've extended these studies, so I showed you the STEP study up to 68 weeks. The STEP extended study in semaglutide looks at what happens when they stop the medication. And really commonly what you see in people is the weight goes back on. So from 68 weeks through to 120 through to 2 years, a lot of the weight's gone back on. Not all of it, notably, on average, people will still retain a 5% weight loss, which is still really crucial and can be a real game changer for people. But that's a real risk of what happens, isn't it? And again, their sugar levels go back up. Again, these references you can look at in more detail if you want to. So this, I think, creates an exciting case for what we can do as health coaches. And this is a study from the Verta group, an American group as well. Some of you may well have seen them. They often get quoted around the sort of low carbohydrate stroke keto type of diets. They call it the carb restricted diet. I'm not wedded to any one particular diet. It is all around personalizing it to people, but I think this shows what you can do. So what they took was this graph here shows the oranges, people who were on GLP-1s, and then at the treatment day or index day, the orange group was when they stopped the GLP-1 and they got picked up with this approach through the Verta group, 154 patients. And they had educational resources, they tracked their sugar and their weight and so on, but they had health coaching. Medical support if needed, and they were invited to peer support groups, but primarily they had health coaching to try and keep them on a metabolically healthy, in this case, carb restricted diet. And when they compare them to case matches who stayed on GLP-1s, who did maintain the weight loss, it was exactly the same. So you see these orange and blue lines matched together. So emerging evidence that actually we can have a really strong role in helping people to maintain their weight loss once they've achieved it. So a little bit now before I break, and Emma, just giving you a little heads up, you in a second, just thought I'd just put a couple. So the questionnaire you sent was really interesting. 23 of you, what it showed to me is that, so 21 of you were health and wellbeing coaches. Of you, 17 of you are seeing people on these at least daily or weekly. So you're seeing this a lot, aren't you? And what that led, you fed back what's been working well from, and it was so valuable to hear your experiences. So what I heard a number of you say was that actually seeing some weight loss and results is really motivating for people, and it's actually helping them to engage with you as health coaches, because starting to see some results, success breeds success. So it's nice to see that. A lot of you noticed this kind of, a lot of your clients, having food noise, and actually this just suppresses it. So that food noise isn't it, is that they just get kind of like, they get cravings for food. They get the need for food to satisfy them when they're feeling down in the dumps, or, they get that sort of, you get that dopamine release reassurance from high sugary, high processed foods, and reducing that allows them to engage better with other more healthy habits. So building healthy habits alongside the meds has been a real success for you, and helping them, as we said, stop to regain the weight loss. You've already seen that. What are the challenges you talk about? Well, actually, that you worry about this being people relying on this just as a quick fix. They're not having to do any of the mental or kind of habit work themselves. They're just relying on this. You do worry about what happens when they stop. You also worry about being asked questions you can't answer. Maybe today helps a bit, but again, I'd be also cautious about the need for you to answer every question. You're not the prescriber. You're not the one who holds responsibility for side effects and for, I think it's very fair to push them back and say your prescriber should be the one that consents you properly and gives you good information about this.
I'm in a meeting. Study here.
Oh, I'm going to just mute that person. That's So, but obviously having a bit of background information, a bit like the top of that pyramid, helps you in your role, doesn't it, of trying to build their self-control. You recognise people are angry at not being allowed this on the NHS, and you do see horrible side effects with people kind of like under eating, losing muscle. So I think it's led to me. This is my last slide, and I'm going to hand over to Emma. Is that some of the sort of key considerations we might? Oh, sorry, I'm just going to keep muting people. So I think I've been guilty of this really. There's a tendency if we're not careful to sort of like do a bit of drug shaming, isn't it? You shouldn't just be relying on a quick fix. You should be doing the work. But I think this is a real asset to people that a lot of people have really tried so hard, haven't they? People have been trying to lose weight all their life, and suddenly they find something that really does make a difference and is genuinely helping people to have results. So we've got to hold that balance, haven't we, between wanting the kind of non-drug approach, but also appreciating the benefits of the drug. And I've personally been on a bit of a journey with that as well, I think. There is this issue about how long do people keep going? Is this something that's going to be a lifelong treatment? Is that the best way to have good health, just to be jabbing yourself with something every week? And does it distract people from the other things that they could be doing to maintain better health? I think undoubtedly, the higher the dose people are on, the higher the side effects and the risks. So actually helping people to stay on the lowest dose, maybe even self-dosing with the kind of like the pens, is something to think about. And I think the most crucial thing for me is the kind of knowledge that if people remain metabolically unwell, so if they're continuing to feed loads of sugar into their system or their diet is not well balanced, that in no amount of drug is going to be able to get around that. And it's so important that we keep people with a high protein diet. Your absorption of protein gets worse as you get older. So keeping up the muscles with a high protein diet and some resistance training. So that's sort of some degree of heavy weight for them. Weight for them can be very small, but just some resistance to keep the muscles working is going to be a really important part of what we do as health coaches. And I'm sure we'll discuss that a bit more. And I say personalize the diet. For most people with insulin resistance, that means reducing the carbs that are going in and encouraging them to have some healthy fats, predominantly unprocessed food. So that's my sort of take on things so far. I said I'd be about 40 minutes. I think I have. So let me stop there. I've got a couple of considerations to come back to, but let's hear from Emma. Oh, thank goodness, another voice, eh? I hear a little bit of some real life stories. Is that okay, Emma?
That's fine. Thanks, Ollie. That was really informative and helpful. Like you say, good to recap as well. But yeah, I'm a health coach down in East Sussex. Been working for about 4 years, and an active health coach working there, but also doing some other support work now, and loosely associate with Peak as well, which is, I think, it's great to be able to share some, like you say, real life experience of what we've been talking about today. So as I say, back to Jay then. So this is a lady. I've just done something trying to be visual rather than it all be about text, around Jay and her current situation. So if I read through, because I appreciate some of you might be on smaller screens. So currently Jay is living at home. They have an adult son with autism. They do own, so they're quite comfortable. They're not under any threat in terms of that. So they've got security at home, but there are stresses and things happening at home. They don't work anymore, but they took voluntary redundancy. So that's the situation. And they tried to socialise as much as they can, but for they, I'm saying they, her, for Jay's time, she finds it quite difficult trying to juggle the needs of being there and looking after her son whilst also being there for herself. She was diagnosed with type 2 diabetes. She says around 8 to 10 years ago. We're not really sure, but it's been a long time. It's been pretty set and substantial. And she's tried to manage it over the years with mixed success. She's also got arthritis and she's currently exploring a fibromyalgia diagnosis. But she feels that her GPs don't really want to be putting in that kind of diagnosis. She reckons that her GP's got some personal opinions on that, and that they're holding off, whereas she's trying to find if that diagnosis is there to help her understand what she faces better. And she's also, because of her son and what she recognises with her son and also the other networks that she enrolls in, she's recognising that actually she herself might have some neurodivergence. So she's recognizing that some of her traits and her personal experiences, but she doesn't want to go down the diagnosis route because it takes years, as we all know. So that's a factor for her as well. In terms of support, she's got one long-term friend that she turns to quite a lot, and she's got some friendly faces at the local chair yoga that she goes to, and she's connected with other parents with neurodivergent children, both children and adults in the local area. So she has got some support around her. In terms of lifestyle factors, as I say, she attends a regular chair low yoga session and she tries to get to the pool. But as it says there, not as often as she'd liked, and it's only really now a couple of times a month. She used to swim much more regularly, but somehow things have just shifted and changed for her. And so that's what we've managed to, put out from the 4 sessions that we've had together. So we've had 4 sessions, approximately 45 minutes a time. It depends on, how chatty she's feeling and how much time she might be able to allocate to the sessions. But within that time, what we've also been able to establish is that she was introduced to coaching for the management of her type 2 diabetes. And it was actually the metabolic health training and then the course that we do around that, that she was introduced to coaching. But then she decided that she might find some one-to-one support helpful after that. It was then that she shared with me that actually, alongside all that she's been doing, the only way in which she's found success recently was by self-funding for the GLP1 medications. So she's been self-funding since March. So she's a few months in now, and she's now finally finding that weight loss is coming. Now, I think what this on the screen reflects, and what we will probably all hear as well, is just the complexity of looking at just what's going on for some of these individuals. And Ollie, in your slide there, your tier, your heart, your pyramid, I can't remember what you called it, sorry, brand new. You were obviously referring to, that foundation level, and although, she's a really strong and resilient lady when you consider what she's gone through in the past. I should say that she's on her own with her son as well. Her husband is or ex-husband is not on the picture, but in terms of what you were saying about high sympathetic tones and things like that, Ollie, I think it's building a picture there for me, and I hadn't really considered that until you said that earlier. But yeah, what we've been able to do through the coaching is just give her time and space and a listening ear with someone who's willing to help her try and just navigate how she's feeling about, what she's doing, accepting it, because she has been quite hard on herself at having to go to the medications. So she's feel that sense of, I can't do this myself, so I've had to go on these medications. It's been an interest in, listening to her talk about that. But in terms of moving forward and her priorities, thankfully they all align with what you were just talking about, Ollie. But in terms of her priority, we've managed to get her to consider. So appetites, as with so many people, has been an issue. So we've been talking about the importance of eating small regular meals. And one of my thing I hear myself saying a lot when working with people is quality over quantity. So if you're not eating as much, try and make sure what you're eating is really good, nutritious and nourishing foods, and it's going to be getting the vitamins and minerals rather than just a slice of toast if that's all they feel like or something. So yeah, prioritizing protein and fiber, but that's obviously for the reasons that you were just talking about. She has got and looked into some of the side effects and the potential side effects around what you were talking about with the lean mass and things. So she is exploring some resistance-based training and exercise options that might be accessible to her. And potentially equally important is more time for herself and self-care. So yeah, that's where we are with Jay at the moment. I'm probably going to have 2 or 3 more sessions with her, and they normally are fortnightly intervals. So that's just an example of where we are with her. But as we all know, just being able to give people that time and space to really sort of consider where they're at, where their priorities are and what's important to them can be really valuable. And following on from what you were saying, Ollie, when we're communicating when I'm writing up the notes and things, we ensure that the side effects and those kind of factors are considered and noted as well, because if their clinician or if their prescriber is then looking at that information, I think it's important that they know, especially because she's self-funding. So that she won't be as monitored like some of the other people who might be prescribed through a more official scene. So alongside that, because we've got Jay's just one of a few people that we've been working with, me and my colleague Lindsay, who's on the call. Hello, Lindsay. We've also recognised that actually there's real benefit in peer support, and we all know that. So one of our key roles here down in Hastings in East Sussex is to provide peer support groups for patient peer support for patient groups, sorry. And so we've pulled together what we're calling Stronger Together, because obviously we're building muscle, but it's equally about that, you know, support and feeling stronger to continue. And so there's just a quick snapshot there of something that we've done. We felt really important to pull a group agreement together from the start, so that people do understand that we're not, you know, one of the things that our clinical director and the clinicians who have helped us sort of put this together, we're really keen to ensure that people weren't giving each other advice, just as you were saying, Ollie, and that if people are in that shared space together, it's about that peer support, sharing their experiences, but certainly not advising on dosage or, you know, and any side effects. We always encourage them to go back to their clinicians if they're concerned. And as you can see, there's a little snapshot there of our last session. We're very early days, so we've only got 7 participants at the moment, but 4 of them are self-funding, and we've got one who's only just started, and then we've got a couple who are really, I've put one in 12 months. Technically, she's 11 and a half months, but we're going to count that as 12 months experience. Yeah, she's been a real sort of asset for the group as well, and she's really helped everybody sort of just, you know, hold on to that hope around sort of just what's possible, because she's had great success. And then there's equally alongside those self-funding, there's also a couple who've been prescribed very recently, and one that's a little bit more established. So it's a really nice mix and blend, and between them as a group, you know, they're just sharing stories. They understand what each other's talking about when they talk about eggy breath and things like that, you know, and so it's just been really nice and valuable to see the potential for people to come together, and us as coaches there just to be able to ensure that, you know, the conversation doesn't, you know, turn into that advice given, and just keep things on track in terms of keeping everybody sort of, you know, safe and keeping things positive as well, because we want people to leave feeling that it was a, you know, worthwhile and beneficial experience to them. So I think that's me. So
Fabulous. Thank you, Emma. That's lovely. And I know you're a great coach. I've seen your coaching, but I just love the way that even the way you present those cases illustrates how you're considering the person's capabilities and their self-belief, perhaps what some people call their activation, and their psychosocial setting background. It's so important, isn't it? Considering all of that. And I know that's what you guys do so well. It's what's adds such an asset to the NHS. Brilliant. Thank you. So we're doing really well with time. And what I know about some of these meetings actually is that in big meetings like this, it can be quite difficult to be brave enough to say anything. And it's also really nice to have a chance to talk. So I'm actually going to suggest that I'm going to put you into a breakout room for 10 minutes in groups of 3s and 4s. Most of you will be 4s. Just to have a chance with some of your other colleagues, reflect on what you've heard. When you come back, we're going to have half an hour for a good chat. You know, because there's so many of you, maybe when we come back, we can, you know, bring you to the chat box to perhaps just sort of like write down some of the key things you've heard or the key questions you've got. And in fact, if I just share my slides again, what I might perhaps lean you towards, you can talk about whatever you like, but you know, this issue of how do we keep people in control? You know, how are we maintaining attention on lifestyle factors, even when the drugs are working? And then there's something about how you stay in the scope of your practice as a health coach, what your experiences are, and how you work as a team, how are you working with the prescriber? That might be the GP, it might be someone privately, but you know, how are you working as part of that whole team for somebody? So I'm going to just sort of draw your attention to that and see how it goes. So welcome back. I in my experience, generally giving you a chance to have your voice heard and chat a little bit, it's always quite nice if you're learning, isn't it? It gives you a little bit of a pause, particularly from the presenters anyway. But you're a big group, so with that in mind, obviously if you're going to struggle to write something, I'm really happy for you to put your hand up and make comment or ask question, but it might be good to go to the chat box and just if each of you just sort of like highlights maybe a comment you've got or a question you might have, and we'll try and work through those in the next half an hour.
Can I just ask one question, Ollie?
Please, Lindsay, go for it.
Because I'm fascinated with it. So the food noise side of it, obviously hearing a lot in the press, everything as we all are, about how it kind of stops that craving and that push to food. My question is, that food noise that's being described, is that the same for everyone clinically, or just because I had one patient that really dove into this before it really gained popularity about GLP1, has really done their research. And she'd kind of described it, hers was a stronger level. I don't understand this at all, just why I'm asking. Do some people have more of that than other, or have we all got the same? So for example, I look at it, okay, I still crave food, but I can't the same way. Or is it different? Do some people have it worse? Some people have it better?
Yeah, that's a really good question, Lindsay. And I'm not a world-renowned researcher on this, but I guess I can speak from it generally that absolutely, I think people are different. But what we understand about how the GLP-1 protein works, it tends to affect the reward center in the brain. So we know that food, particularly highly processed food, sets off the dopamine reward center in the brain through various pathways, and GLP-1 seems to block that. It's why, if you're feeling down in the dumps or a bit low and you have a chocolate bar, it kind of boosts you up. You get the sugar effect, you get the reward effect, and the kind of, it's the dopamine first before the sugar that actually gives you that bit. On the flip side of that, some people are experiencing, you might have experienced this, that actually block that reward center, and actually they lose the enjoyment of other things as well. So they might lose the enjoyment of exercising or socializing. So it's just something to watch out for. But it is different in different people, and I think that's the universal feature of every medication, isn't it? It'll be a bit different for everybody, Lindsay.
As in, sorry, just you as a person. So I know that people will say, oh, before I started taking it, this is more in sort of social media stuff, I just was driven to food. And I sit there, and this is from a personal point, I think, well, so do I. Like, I stress eat. Mine's usually Haribo and Cadbury's is the two that I'll go for, and that's what I have to personally work through hard. But I don't know whether it's that actually, am I experiencing what someone that is putting that kind of a video out is experiencing, or is theirs stronger than mine? I don't know. That's what I wanted to more gauge before we go on. Are we different, or are we kind of similar?
I'll throw that open of whether other people have seen a big variation, because your collective, I mean, my personal feeling is that from the patients I've seen, absolutely it's very variable. For some, it's like anything, isn't it? Some people are really vulnerable to certain aspects of life and their personality. Other people are much more resistant to different bits. So, but what anyone else had experienced that? Someone where food noise has been a major thing, or others where it's just really not a thing?
It's food noise from the patients that I've seen has dramatically reduced for 99% of the patients. The relief that they get, that they're not thinking of their next meal all the time has been phenomenal. So I'd have to say that the food noise is definitely one of the most noticeable changes in the patients that I've been working with.
Thanks, Alice. And is it a bit variable? Would you say some people that's a massive thing in terms of like a problem beforehand, or do you think for everybody that's an issue that's helpful?
I think it depends on the person themselves, because some people are some people that I work with don't work, so have more time to think and aren't distracted, whereas other people are working or have kids and are more distracted. So it depends on the individual. So if it isn't mentioned by the patient, I might raise the question and do you find that you're thinking a lot about food or less about food, or is it about the same compared to before you started? And some would say, oh, actually, no. Now that I think about it, I'm not, it's not consumed in my thoughts like it used to be, but yeah. So.
Brilliant. Very helpful. Thanks, Alice. And I can see Emma's got a hand up as well. Do you want to come in, Emma?
Just to say that I think from my experience, both personal and also professional, I mean, I think it depends on people's relationship to food, and so much of it can be learned behaviour. And also, obviously as we grow up, how the different people respond to emotional, things, stresses. Food sometimes fills a void, whereas other people turn to exercise, some other people turn to other things. So it really varies, isn't it? And I think if people do start to use food as a coping mechanism when it comes to some of these things, then that's where it's extra hard for them. And I think that's where most people then really find that sense of relief when that is no longer there. But yeah, well, as I work closely and also myself with, you feel like you've got a lifelong narrative about should I eat this, shouldn't I eat this, and then if that's gone, that must feel quite a relief. But Ollie, similar to what you said, we've also got feedback from people saying that other noises quietened as well. So yeah, it's factoring. So I can see another hand up, so I'm going to sit on my hands and keep my mouth.
No, thanks, Emma. Really useful. Kate, do you want to come on in?
Yeah, it was just to really point about, as health coaches, the advice about spikes and crashes in the blood sugar. So when we were talking earlier about why do maybe some people crave the noise more, but once you've created the spikes and crashes, because of eating the wrong things, whether it be high in carbs or the sugar things. It's those impacts of the crash, the hunger, the sugar cravings, the depression. And the more people are going in and out of that, then of course more people are going to experience it possibly higher than another person.
Worth remind. So it calls back, doesn't it, to the sort of pre-metabolic state and people's habits beforehand, perhaps influencing it. Thanks, Kay. That's really valuable. And just whilst we've got you there, I noticed you put in the chat about sort of gender and age and sort of the menopause factor as well. Do you want to comment a little bit about that? Because I think that's important to consider, isn't it?
Yeah, Colette's on the call with me at the moment, and we're doing a lot around menopause. I don't know if people are on the call experience a lot of these. My patients certainly are in the menopausal age, a lot of them, who struggled because of the weight gain. And obviously one of the downsides to menopause is the loss of muscle waste after the age of 40, that 10% continuous. And then if they're already going to be then taking GLP1 that's going to impact them, then that's a more important conversation to have about strength training and the build-up of the muscle to maintain that.
Yeah, thanks, Kez. That's a really important other factor to bring in, isn't it? And I think it's such a key thing. I've seen so much in our diabetes work, actually, that building muscle is a really effective way of improving your metabolic situation because your muscle soaks up the sugar. Remember, I talked about the insulin putting sugar into the tissues. If you've got more muscle, it soaks it up and provides a much better sump and reserve. And it can be a real game changer. So if you're losing that with these injections, you're going to be worsening the metabolic situation. If you're losing it with the menopause as well, it does happen to men as well, perhaps a bit later down the line. It's really important. Yeah, something to consider. Thank you. Elizabeth, I can see you've written in the chat there around sort of nutrient dense foods and that people can become malnourished. Do you want to speak a bit to that? That sounds a really important thing to talk about. Are you happy to unmute and talk to that, Elizabeth?
Yeah, I think with patients that are just focusing on weight loss as their goal, it's very easy for them to just carry on. I think we've already touched on this, but where they just focus on whatever they need to do to lose weight, and then they're not focusing on nutrients. And so it's not just the loss of muscle, but they could become malnourished. So that was a concern. And also how, I mean, we're finding that there aren't that many people who are being prescribed these meds, and those that are, they don't want to engage with health coaching. It's almost like, well, I don't need your help because I've got this miracle drug, and that's what I need and not interested. Yeah, so unfortunately, but that's why I'd really like to see somewhere where if patients are prescribed these meds, that actually the deal is they have to also have a certain number of sessions with the health coach, like they have to engage with the health coach. It's hand in hand. It's a package, but whether that'll ever, I don't know if that'll happen. But
yeah, it's a nice thought, Elizabeth. And I wonder if I throw that open as to where anyone's got any good strategies of things that have worked. Obviously, you know, you don't want to undervalue the value they're getting from the medication and the kind of positive surge that creates, but you want to keep them engaged in a more holistic approach. Is there anybody else got any strategies they've used that have worked well in that front? Kay, have you got your hand up on that one?
It wasn't just about the strategy. It was about, I think we all know that different CCGs, because we've not got to that stage yet of being able to prescribe the Mounjaro. Certainly our CCG here, it won't happen until all the background support is there, like Oviva, where we've got access to psychiatrists, nurses, nutritionists. And I think we've got an important role, because we're having to say this probably daily at the moment, is until those services are set up, that is why those drugs won't be prescribed initially, and again only for those 4 out of 5 conditions, and that it is a must that coaching and support is there, because otherwise the money, the cost, the time given to patients to do this, we don't want the long-term impact to reverse that. So I think it's our job to keep promoting the importance of why coaching is there, whether we've got access yet or not.
That's beautifully said. Thank you. Great. And I can see, Amy, you've got your hand up as well. Do you want to come in on that?
Yeah, I was just going to give an example of how I supported a patient. So she was on Mounjaro, self-funded, but we worked on her food noise alongside it, as well as her emotional eating, and she was able to not. Then she couldn't afford the drugs, but she didn't actually want to go back onto them because she worked through what her food noise was, what her emotion, why she was emotionally eating, and she was able to get to a place where she didn't need the drugs anymore.
Brilliant, brilliant. That's a real example, isn't it? That getting to the root cause and really working with someone's emotions as well as their sort of like access to medication or whatever. I really like that. Thank you. Lindsay, you got your hand up. Please come on in.
Yeah, sorry, I feel like I'm taking over. I'm going to stop talking in a minute. I was really interested. I'm more looking, and I'm open with this with patients. If they ask what I think, I'm like, okay, I'm going to be very neutral, pros and cons, But actually, what I'm really personally interested in, if we fast forward 1 year, 2 years, exactly like you did in your graph, and you see actually what that weight regain is anyone tracking out of interest people that, and the numbers of people that are taking these drugs privately, NHS? And also the impact potential on us as coaches in about a year or 2 years' time, because I don't know if anyone else is feeling the same. I feel like, are we going to get an influx of people? Is that being tracked to then prove really we do need the coaching and the lifestyle change alongside this as well?
It's a really good question, isn't it? I think we'll be in this space and we'll watch that space, won't we? I mean, we certainly saw that with obesity surgery, and it really backs up what Kay just said there, that actually the people that weren't prepared emotionally and mentally for the surgery would keep eating even around their kind of structural changes. It'd almost be sort of like forcing food down. And I think that's the dilemma. You have to do the emotional work as well as the sort of physical.
Well, that's exactly it. I've come from private healthcare, and I was involved in the bariatric side of things. And that's they'd have a psychologist on board. You had to have sessions with her. They had a dietitian, all of it. And you think this is, I don't know how much is happening privately. I've not looked into it personally, but it just goes to show you do need it.
Absolutely, I think that's it. Yeah, Kay, I can see your hand up again. Come back in, please.
Sorry, again,
No,
I'm sorry. I feel like we're all kind of probably got lots to ask. I've got something completely different. I've got one patient who has taken Mounjaro for now 8 months, and initially it was for the weight loss. However, this patient was alcoholic. The one thing it has been successful on is actually stopping the noise with alcohol as well. Has anybody else had experience of that?
Lovely to throw that open. There's definitely literature about that, about how it's been used for addictions. Yeah. Anyone else? Alice, look like you're coming in.
Yeah, I've had patients who have dramatically reduced their intake of alcohol because their desire for it has lessened. So they just don't drink anymore. These are not alcoholics though, and they don't abuse alcohol. So I think it's a very different thing. Yeah.
Thanks for sharing. Anyone else had that sort of experience, or any other questions that you want to bring to the table?
Sorry. Oh, sorry. me again.
Okay, go for it.
Just on the back of that alcohol, has anybody had anything? Because I'm curious for the addiction, and I don't know, Ollie, if you know any data on this around the GLP1s. But this particular patient as well is also a cannabis habit as well, but it hasn't had the same impact on that.
Interesting. Yeah, I mean, I think that comes back to what we were saying earlier on, isn't it? People are different, and different parts of the brain work in different ways. I don't know specific data around it, but I think your own personal experience is really valuable, and it just, to me, just emphasizes why you do have to treat every person individually and sort of learn as you go together, really, to a degree. I can see Amy's put there that it helped with the noise with an ADHD patient. Do you want to say a bit to that, Amy, as well? Because that's sometimes an overwhelm for people living with ADHD, isn't it? There's just too much going on in their brain.
She said to me that since she's been on her drug, I can't remember which one it was, she said the noise has stopped for her, and she's found it amazing. Working alongside myself as well, but she's definitely said, like, at night she can go to sleep now and not have to worry about the noise in her head, and that was very very interesting when she said that.
Yeah, that is interesting, isn't it? Definitely. And Emma, you've put in the chat there as well about perhaps building in on that value of peer support, isn't it? And that gives an extra resource to people. Do you want to say a little bit more about that?
I mean, I was listening to what was there as well, and I don't know, now my head's in two places, but yeah, it is around, as I was saying in our group, sometimes when you're working with the individuals, it can be, you don't always get that connection the same as you do if you've got people with that shared lived experience. They sort of connect a bit better. And so if we're trying to encourage people to be thinking about the importance of some of those wider lifestyle factors, if we're not able to achieve that on an individual basis, perhaps sitting alongside others where they might hear other people who are more open to it, can help with that process as well. And as I was said in there as well, you know, group work it can be really cost effective, but if you can get on board with the people who make the decision making around these things, we've got some really helpful, great clinicians who see the potential in working and supporting us and doing like an information session for people to come along to, and then follow up with the opportunity for peer support work to be able to try and help with that. So it can happen. You just got to, you know, try and say that it can happen for people. You got to come up with the ideas, haven't we, and then try and take it forward. But
yeah, I think that's absolutely
the other point I was going to make, sorry, was what Amy was saying around the neurodivergence and the noise. That only then adds to the sense of people feeling that this is something that they fear more. The idea of what happens when this finishes is then more than just the weight gain, isn't it? And the potential of weight gain, it's that all of that will come back and they don't have those you know, sort of, you know,
coping mechanisms.
Yes, yeah.
I think they're really live questions to hold, aren't they? And then I think this is where health coaching can have real value, is that, you know, you're giving people alternatives. If they've made some progress, you're giving them things that can help sustain. And I noticed Donna put there around, once the food noise goes, actually you can find you're going to get, you often get sort of real neglect of proper eating. Donna, do you want to speak a bit to that? Is that Donna from Wakefield, is it? I don't know if you are happy to unmute, Donna, and just talk a little bit to that, to perhaps seeing people whose eating habits have really gone off once they haven't got this kind of drive to eat.
Yeah, hi Ollie. I'm thinking a couple of patients that I've had who I was working with on weight management, but they were all over the place with their eating because of their sort of ADD kind of lifestyle and focus, and it was quite hard, but we were making progress. And then the jabs became more accessible and they got them privately. And then I sort of saw them once or twice more, and then they sort of disappeared. But those couple of times that I was seeing them, they were, you know, barely eating anything. So all the work that we'd done on trying to sort of think about portion size and balanced plate and, you know, to make sure they were getting the nutrients in while they lost weight. You know, you hope they maintain it, but in fact, it just seemed like they were just barely existing, because once that food noise was gone, they'd sort of forget to eat. So you sort of say, so, you know, so what have you been eating this week? Oh, well, I don't know if I ate anything actually on Tuesday, because, you know, I just don't have all those sort of like thoughts about food in my head now. So, you know, sometimes I just don't bother eating. And you think they're not then getting the nutrients, and you're then going to get nutrient depletion, and you're going to get more things like bone problems as, you know, they go on, and etc., as well as, you know, messing up their digestive systems.
Yeah, it's really good points to bring to the table, Donna. Thank you. And I think these are things, again, just to be guarded about, isn't there? You know, there's no one size solution for this, but being receptive to it, really important. Yeah, and drawing people's attention to it in the way that we do in coaching. Good, brilliant. Thank you. I'm just drawing attention in the chat. I've put a couple of. I talked about Mark Cozzolo, who American GP, who has written some really useful stuff, and he's written there a patient handout, which he's happy for us to share. It's just the one they use locally. Some really sound advice for patients about these, and then also his workups a little bit higher up in the chat. 114, I put it in there, around the sort of workup people should be expecting before they're put on these drugs. And I think, maybe holding your prescribers accountable to look, are you doing this with people? And, I can offer the wraparound support, but let's make sure that we are putting this on the table for people. So I think really good couple of documents. And I'm also going to share back on the slides we talked about resources. So Mark, this is a sort of a lifestyle orientated podcast for sure. So the Metabolic Mind, and it's led by people that probably lean towards self-management rather than medication. But I particularly like Mark's work because he's as a fellow GP, I think he's really minded of real life situations and the value of a medication. He's a prescriber. He works a lot with veterans in the United States, and he's seen so many success stories of people who were stuck. So I think he's got a really nice balanced view. So anything that involves Mark, I would be really supportive of. And like I say, I've used some of his slides with permission, and I'm sharing a couple of his resources that he uses in his clinic. He's using a lot of people with these drugs, so much more involved than me. So just coming towards the end, the other thing that I would really value as well is if there's time for a couple more questions, but I'm just going to put into the chat a link to a little bit of feedback. It's very, very brief, but it would really help me if you're happy to put on it's just 4 questions. But at the end of it, if you're happy to share your email on our newsletter list, I'll send out this recording in a format that you can share. I'm going to upload it to YouTube, and then you can share it around. I will probably also on our website, on Peak Health Coaching website, share an abridged version of some of the slides so that we focus in on the really important bits as well. Again, the idea of this is to be a resource to you guys. It's not a sales pitch in any way. It's just to try and keep us working in a really useful way. Because for me, the whole motivation of supporting health coaching is because I think it's so important to what we do in the NHS and beyond. So anything we can do to try and drive that is really important. So I've just put that in there. If you're happy to click on there and just give us a little bit of feedback, that really helps. And if you're happy, if you want to go onto our newsletter, we won't do it without your permission. Just put your email on there as well. We send out a monthly newsletter with top tips and links to talks like this that we do. Obviously there's signposting of some of the other training we do. Emma works with us, does our group training course, which is really popular, and we are just about to launch a course around metabolic health. It'll be 2 half days that takes this a bit deeper, but it's good to have free stuff as well. Absolutely. So
yeah, Ollie, can I just say thank you, because none of this was planned, was it?
No.
I just you responded to me asking a question, everyone came forward, and it's been really valuable today just to hear and read your presentation. Thank you so much for responding to that, but also to everyone. It's obviously, like Lucy and Lindsay and those I was in the room with, it was really helpful to have your viewpoints and just read down the chat and be able to resonate with so many of the comments. As you say, it just helps us recognize that we're all facing very similar challenges, but with challenge comes opportunity, everybody, doesn't it? So
absolutely.
Thank you, Ollie, I really appreciate it.
I will, well, in fact, I've got the emails that were circulated before. I will use that to send out a link to the recording as well, and feel free to send it out far and wide. Do you know what I mean? It's if it's useful, and it's useful for our colleagues to have that background info, please do share it, and keep up the great work. I mean, you guys are pioneers in the NHS. Health coaches have been out there now for 3 or 4 years, haven't they? I know there's a little bit of a pullback because now PCNs can invest in GPs and nurses. In some sites, they're pulling back. But interestingly, I'm seeing many sites who are saying, actually, no, we really must keep our health coaches. And I think the role is ever growing and ever needed. And as we move into new neighbourhoods with slightly different decision making and slightly a remit around looking after long-term conditions and prevention, I think we'll see health coaches surge again. So what you're doing is just groundbreaking. I really appreciate all the work you do. Right, we've got 3 minutes left. So if there's any other questions, I'm more than welcome if you want to pop off. But please do just click on that link to the feedback. It really helps me, and we can keep in contact with you.
I have a quick question. I don't know where my yellow hand is on or where it was. Is there a group? Is there a group that actually looks at the numbers? start, middle, and end with the cohort of NHS patients that have started Mounjaro or whatever, to see how it's actually working. Is there an ongoing kind of cohorts that are being monitored, or is it just a case of let's see how this goes?
I'm not aware of it, but I mean, perhaps the other thing to shout out for is I know that Jim and Jenny and Tracy have just set up this new association of health and wellbeing coaches in the NHS, which is going to be free to join. And I think it could be a really good forum to do exactly that sort of thing, Alice. And I think I'd encourage you all to sign up for that. I'm equally supportive of the UK International Health Coach Association. I think they do some really good stuff as well. So I think there's emerging supporting frameworks where I'd really encourage you to get together and put those things on the table, Alice. Let's do it. Let's do it together. Yeah.
Okay, thanks. And thanks for today. It's been great.
Brilliant. Well, thanks, folks. Really appreciate your input, and it makes it when people like you, Alice and Kay, join in. Thank you. And thanks to Emma as well. Okay, folks, I think I will close it there. Have a good rest of the day. Have a nice weekend, and feel free to share when I circulate the recording.